A very good evening to all. We with CCI welcome you all for today's webinar, which is about the waves and the graphs which we see in ICU. And I thank the CCU think tank, which is getting up these different kind of webinars. So basically, a critical care ICU is a maze. We can understand with the wires and all. As pulmonologists, we are so used to the waves and graphs, but they are on the spirometry or the body works, or and the sleep study waves and graph. But when it comes to critical care, that's a different ball game altogether. So for all of this to fall in place, we have a great esteemed group of panelists, which includes two critical care specialists, a pulmonologist, and two cardiothoracic surgeons with us, who will help us understand the nuances of these monitoring systems. So let's begin with Dr. Nilanjan. I'll just give you a brief about Dr. Nilanjan. So I think all of us know that the 5 vital signs, the heart rate, the blood pressure, the respiratory rate, the temperature, and the oxygen saturation is not really enough for us to take treatment decisions. So where and what places do we monitor really small kind of a short duration, so we'll try to cover as much as possible. So for today, I welcome Dr. Nilanjan Umesh, who has done his DNB in respiratory medicine and his fellowship in critical care. He's a pulmonologist and a critical care physician at Rajagiri Hospital, Kochi. We have with us Dr. Jnanesh Thacker, our cardiothoracic surgeon, senior most cardiothoracic surgeon, who has done his general surgery and MCH in cardiothoracic and cardiovascular, as well as he has done a transplantation for 2 years in the US. He's currently the director of lung transplantation, minimally invasive lung transplantation, and lung transplantation at Merengue Sims Hospital in Gujarat. We have Dr. Mehul Thacker, who has done his MD and DNB in respiratory diseases, and he was an ex-assistant professor at KEM Hospital, Mumbai, and is currently a consultant pulmonologist at Jupiter Hospital, Thane, and Fortis Hospital, Mumbai. We have Dr. Ravi Chandra, our cardiovascular surgeon again, who has done his DNB general surgery, MCH, and an MRCS. He's a consultant and head Department of Cardiovascular and Thoracic Surgery at Siddhaganga Hospital, Tumakuru. We have Dr. Arnab Bera. He has done his respiratory medicine MD and DNB, and again he's a fellow in critical care, fellowship in critical care medicine. He is a consultant with the Department of Respiratory Medicine and Critical Care at Medica Super Specialty Hospital, Kolkata. I welcome all panelists, and I hand over the mic to Dr. Nilanjan, and he will explain to us in short the modality of end-tidal carbon dioxide monitoring in the ICU setup. Dr. Nilanjan, please.
Good evening, everybody. On the onset, I would like to thank CCI for giving me this opportunity to give a talk on this important topic, the importance of EtCO2 monitoring in ICU. So what is capnography? Capnometry is the measurement of carbon dioxide in a sample of gas, and capnography is the continuous monitoring of the concentration or partial pressure of carbon dioxide in respiratory gases. It is represented in a graphical form with time on the x-axis and the expired partial pressure of carbon dioxide in the y-axis. As you can see in the bottom part of the screen, the monitor which I am showing you. Now coming to basic physiology. What is dead space? Dead space refers to the inhaled gases that doesn't participate in carbon dioxide clearance. There are mainly 3 sources of dead space: the anatomical dead space, which consists of the trachea and the large bronchi, and with each breath, gas enters these areas but doesn't participate in gas exchange. Then we have the instrumental dead space, mainly for the intubated patients, or even the tubings and the circuits, or any other device which is interposed between the patient's airway and the site of the fresh gas insufflation, be it a ventilator or a Bain circuit. And then the alveolar dead space, which is the dysfunctional alveoli, which receive ventilation but don't participate in carbon dioxide removal. So coming to the understanding of EtCO2, arterial carbon dioxide should always be higher than EtCO2. In extraordinary rare cases, the EtCO2 can be slightly higher than the arterial carbon dioxide, especially in pregnant patients. But in our everyday critical care practice, it's reasonable to assume that the PaCO2 is above the EtCO2. The gap between the EtCO2 and the PaCO2 is a reflection of the amount of dead space, and any increase in dead space will widen this gap. In patients with normal lungs, the gap is typically 3 to 10 millimeters. So coming to a very important slide, the capnographic trace. So there are basically 4 phases of this trace. First, we see the phase 1, which is the inspiratory baseline, which represents the inspiration, and therefore no carbon dioxide is detected. Then we have the phase 2, the expiratory upstroke, which represents expiration of both the dead space gas and the alveolar gas from the respiratory bronchioles and the alveoli. And then the phase 3, that is the alveolar plateau, which represents expiration of alveolar gases. At the end of phase 3, it's very important to note, the end of phase 3, the maximal value of carbon dioxide measured is equivalent to the EtCO2. And then the phase 4, which is the expiratory downstroke, which represents the beginning of the next breath with the carbon dioxide content again returning back to zero. So coming to the uses of EtCO2. First and foremost, it is the gold standard to confirm endotracheal tube placement. This is endorsed by all societies like the Difficult Airway Society, the American Association of Society of Anesthesiologists. Everyone says always, always, always confirm an endotracheal tube placement with capnography. Some other salient points, esophageal placement may also generate a brief EtCO2 tracing, but it will rapidly be extinguished within about 6 breaths. The initial EtCO2 signal may be caused by carbon dioxide, which has been insufflated into the GI tract during bag and mask ventilation. Even endotracheal tube placement in a right mainstem bronchus will also reveal a normal EtCO2 tracing. That's important to note. ET placement above the vocal cord in the glottis may also reveal a near normal appearance of the EtCO2 tracing. And the absence of an EtCO2 tracing should be interpreted to mean that the endotracheal tube is in the esophagus and requires replacement. That is, no trace, wrong place. Pulse oximetry may take minutes to drop, so a normal saturation should not be reassuring if there is no EtCO2 return. Please, we have to change the position of the ET tube. So this is how the difference of the EtCO2 tracings. The first one shows how the carbon dioxide levels gradually return to zero in an esophageal intubation, and in a tracheal intubation, how we get the characteristic curve that has been discussed in the beginning slides. So now EtCO2 in cardiac arrest. EtCO2, it reveals the amount of carbon dioxide which is cleared from the body and is a reflection of the quality of CPR as well as the body's carbon dioxide production. So EtCO2 values are very important to coach a resuscitation team on the quality of CPR being produced. If the EtCO2 is less than 10, that means our CPR technique is not adequate and probably we have to ask a different provider to attempt CPR. And EtCO2 more than 20 millimeters is always desired. And very importantly, a return of circulation will often cause an abrupt jump in the EtCO2 value. So this is how the EtCO2 value, which is so low, nearly zero, and suddenly when we have the return of spontaneous circulation, we see an abrupt jump of EtCO2, and then we come back to the normal tracing. Okay. So even without palpating the carotid pulse, sometimes we can possibly see whether a patient has attained ROS. Now there are certain studies which have evaluated the EtCO2 after 20 minutes of CPR. If the EtCO2 less than 10 millimeters, it suggests low likelihood of survival. If it is 10 to 20, it represents a gray zone. And if it is more than 20 millimeters, it suggests higher likelihood of survival. So probably in these patients, we might continue CPR and there is still a chance of reviving the patient. Now EtCO2 in obstructive airway disease, we get something called the shark fin waveform. Mild obstruction, it causes an increase in the slope of the top of the waveform. Severe obstruction, it causes the entire waveform to resemble a shark fin. And this can occur when there is small airway obstruction as well as large airway obstruction. A fin-shaped capnography suggests that the EtCO2 may be substantially lower than the blood PCO2. So this is the characteristic wave when there is obstruction. As you can see, first there is upsloping and then a characteristic shark fin appearance. Okay. Now, why does exhaled CO2 rise over time due to obstruction? Early in expiration, there is relatively unobstructed alveoli which empty, and the gas spends less time in this alveoli, so the PCO2 is lower. When they start emptying, the gas stays longer in the alveoli, so the PCO2 is higher. Now, the relation between EtCO2 and cardiac output. Rapid changes in the cardiac output can cause transient fluctuations in the EtCO2. For example, if a patient is having a cardiac output which suddenly drops from 5 liters per minute to 3 liters per minute, immediately there would be a reduction in the carbon dioxide delivery to the lungs. So, there would be a sudden drop in EtCO2. So, if a patient is suddenly having an MI which has led to a sudden decrease in cardiac output or even in pulmonary embolism, we often see a sudden drop in the EtCO2 levels. However, over time, the CO2 would build up in the tissues and it would increase the venous blood carbon dioxide tension, which eventually elevates the EtCO2 to its prior levels. After re-equilibrization, the drop in cardiac output would have no lasting impact on the EtCO2. Now, coming to the relation between EtCO2 and fluid responsiveness. As we all know, fluid responsiveness refers to the ability of additional volume to transiently increase the cardiac output. End-tidal carbon dioxide may be useful as an easily as well as immediately measurable index of changes in cardiac output. So, if there is an increase in the EtCO2 by more than 5%, it appears to have a reasonable sensitivity as well as specificity for fluid responsiveness that has been conducted in various studies. So, if, for example, we give a fluid challenge or we do a passive leg raising test and see that there is an increase in the EtCO2, that itself is a marker of fluid responsiveness. Now, EtCO2 and patient efforts. There might be small diverts which are seen in EtCO2 pattern according to the patient efforts, which occur synchronously with the patient effort. And the significance at the most basic level, it reveals that the patient isn't paralyzed. Notches occur during expiration, which represent missed triggers. The patient is trying to trigger another bed, but failing to do so. This may also be a sign of autopeep or an incorrectly set trigger sensitivity. Notches can also be a sign of flow starvation in the ventilator is set in a volume cycle mode. So it can be either an inspiratory problem or it can be due to flow starvation. And finally, coming to EtCO2 in weaning patients. EtCO2 provides a real-time indicator of carbon dioxide rise and hypoventilation. There is a progressive rise in EtCO2, which is a sign of weaning failure. This has also been elicited in a journal which has been discusses the role of capnography during weaning from mechanically ventilated patients with COPD. And it showed that the PCO2 level and the EtCO2 they correlated with each other when before, during, and after a spontaneous breathing trial, and hence EtCO2 can be used for weaning. So no need of doing repeating ABGs or your blood gases. EtCO2 is quite good enough to assess a weaning of a patient. So finally, can we replace PCO2 with EtCO2? EtCO2 only strategy that can be used, that is, if there is monitoring carbon dioxide clearance based solely on EtCO2 values, it can be considered in certain conditions. First and foremost, there should be a good EtCO2 waveform which reaches a reasonably flat plateau and the values remain stable from breath to breath. The patient should not have any significant lung disease. There should be absence of substantial hypoxia. And in conditions in which precise CO2 control isn't necessary, for example, when there is no elevation of intracranial pressures, no right ventricular failure due to pulmonary hypertension, and when the patient is not pregnant. And finally, in the absence of any severe metabolic pH abnormality. So PCO2 can indeed be used, but then we cannot all the time rely only on the ETCO2, probably on the PCO2 also. So my take-home message is ETCO2 is very important and an integral part of ICU monitoring. It is simple, easy, and relatively inexpensive. ETCO2 is the gold standard for confirming endotracheal intubation. ETCO2 waveform gives a lot of information regarding the patient respiratory and cardiac status, and ETCO2 monitoring is very important during CPR and post-CPR patients. In my clinical practice, I use ETCO2 right from the beginning after intubation of the patient, right up to weaning and extubation of the patient. This has reduced a lot of use of unnecessarily blood gases and ABGs. Thank you.
Good evening, everyone. I first of all would like to thank CCI to give me this opportunity to speak on ultrasound in critically ill patients. Ultrasound, as we all know, has become one of the most important non-invasive tools for diagnosis, specifically in ICU setting where shifting the patient from one place to another for an X-ray or for a CT scan might be difficult, or maybe it's an infectious patient, a suspected COVID patient you can't shift. Ultrasound can help a great deal. In the last decade, there has been a lot of advancements in the techniques to assess the patients via ultrasound bedside. So let's start. Let's start with the why. Why we need ultrasound. This was one study published way back which showed that lung ultrasound had a good sensitivity and specificity for consolidations, pneumothorax, which was even missed by chest X-ray, pleural effusions, and also with good protocols, you can diagnose interstitial syndromes also. So in their unselected general ICU population, lung ultrasound has a considerably better diagnostic performance than chest X-ray, and specifically can be used as an alternative to a thoracic CT if the patient is not stable enough to get a CT done. This is in general with all the few studies I could find, this combined sensitivity and specificity in various conditions. And as you can see, this is good enough for a critically ill patient, probably on a ventilator or on inotropes. What do we use for an ultrasound? Since this is it's a very vast topic, I'll try to concise it as much as possible. Maybe I might go a little fast, but then probably we can take it up in the discussion if needed be. Ultrasound probes can be of three types that you get commonly, and in each has their strengths and weaknesses. In an ICU setting, the phased array probe is the one that you use. In general, the lower frequencies have better penetration, but the resolution is not so great. Higher frequencies would have a better image quality, but their depth is limited. And the phase array one is the most commonly used because it's small, it can be moved anywhere. It can be used for cardiac purposes also. And I'll show you how we examine the patient. In difficult positions, the phase array probe is a good enough probe to be used. The linear probe is used only if you want to just detect whether there is an effusion or no effusion. The depth is limited and it's a good probe for that. This is just basics of ultrasound for all of us to remember that air is hypoechoic, so it's a high scatter. Fluid, blood will have a very hypoechoic structure. It'll look, blood may look a little, have some shadows, but fluid, a clear fluid will look purely hypoechoic. Bone and muscles and solid organs are going to be echogenic. One more basic thing before we go ahead is B mode versus an M mode. B mode is called as a brightness mode, and M mode is basically, it's a pulses emitted in quick succession. So it's more like a video recording in a M mode. And how do you do it? These are the zones you're going to see. As you can see here, zone 1 is in the anterior part, which you can divide in upper and lower, 1 and 2. Zone 2 is in the axillary area, again upper and lower. Zone 3 is in the posterior part, which you can divide in upper and lower, 1 and 2. Zone 4 is in the posterior part, which you can divide in upper and lower, 1 and 2. Zone 5 is in the anterior part, which you can divide in upper and lower. This is again shown in a supine position where the patient, you may not be able to tilt the patient, or patient is so sick that you can't move the patient anywhere. And zone 3 is where you lift up your hand, and again you examine in upper and lower, that is 5 and 6. These are the zones that you need to screen for getting a diagnosis. And the most I'll speak, there are multiple signs that you can see. I'll just speak about the basic ones. The most important that you see is a bat sign. Here you can see what bat signs mean is the characteristic pleural line along with the adjacent rib. So this looks like a bat. So here you can see on the video, probably I am sure you might be able to see, it's a very short clipping, but I'll play it again. This is called as the bat sign. Then we have something called as the A lines. You should be able to identify the A lines. They are echogenic lines that gradually fade horizontally below the pleural line. So this is the shiny pleura that you see, and below that the horizontal lines that you see are called as the A lines. Their presence indicates air gas interface below the pleura, and which reflects the ultrasound waves back to the probe, and causing the movement of the waves to and fro from the transducer and air beneath the pleura, resulting in this artifact. So this is the A lines artifact. Then we come to the B lines. Now B lines are vertical. They are vertical. They look like a comet tail. They used to be called a comet tail. Typically, you see around 1 or 2. So it starts from the pleural line. Oh, sorry, going back. It starts from the pleural line, usually reaching the bottom of the screen, and they are hyperechoic. They start at the pleura, they move with respiration, and they erase the A lines. Again, I'll play this video. You can see those B lines that are seen. A maximum of 2 B lines that you can see is considered as a normal lung. Okay. If you don't see them originating from the visceral pleura, you have to rule out pneumothorax. If you see increase in the number of B lines, then probably the lung density is increased. And here you can see whether it's a focal increase or it's a diffuse increase. If it's a diffuse increase, you can think of an interstitial pathology. If it's a focal increase, focal pathologies like consolidation might be present. Then the important thing is the lung sliding sign. The lung sliding sign is with tidal inflation, the normal lung, the visceral pleural slides against the parietal pleura. On ultrasound, movement is below the pleural line, and the movement is best appreciated on this M mode that we do. That's more like I told you, the video mode, and which looks more like a seashore. The smooth horizontal lines above the pleural line and the sandy appearance below the pleural line. One more point that you need to know is the lung point. This is the alternation of normal lung and the abolition of the sliding. Here you can see, I'll show it again. One sec. This is the contact point between the collapsed lung and the pneumothorax air collection. It will be absent if the lung is totally collapsed. Otherwise, you might be able to see the lung point. So to summarize, you can see a pleural, going back, you can see a pleural line, that is the white arrow which is marked here. This is the bat sign that I spoke about. Then you have the B lines. If you see more than 2, then that means there is a pathology. Around 2 is considered to be normal. If you see a consolidation, this is what you will see. This is the echo-poor image, which is next to the pleural line, and here we call it as a shred sign. A very small effusion that you can see as a mnemonic effusion, which is present. This is the hypoechoic area. You can see the pleural line and the B lines which are there. And this is the M mode of the same scan, which shows a presence of fluid. This is the lung, which is consolidated, as you can see. This is the liver, and this is the small amount of fluid that you see. So in a patient who's critically ill, ultrasound can help you to differentiate whether the patient has pneumothorax, whether there is a pleural effusion, whether there is a small consolidation that you're missing out, whether you need to go and do a BAL for this patient. Now, there are many other signs and many other things to be discussed in an ultrasound, but this is the overview of how ultrasound will help you. And this is how you This is the protocol that you can follow in patients who have acute respiratory failure with an ultrasound coming to your aid. If you have a patient who has acute respiratory failure, you start with the anterior fields where you look out for A lines, B lines. If you see no sliding sign, then look out for a lung point. If you don't see the lung sliding over the pleura, then you see for a lung point. If there is an absence, or if you find a lung point, then that means there's a pneumothorax confirmed. If you see a sliding sign, then look out for the shred sign that I showed you, the subpleural consolidations, and that could uh, help you figure out if there is any focal area of lung pathology that you can see. After the A lines, look out for the B lines. If you see B lines are more in number and they are diffuse, then you can consider an interstitial pathology. If you see a focal B line, increase in number of B lines with thin regular pleura, normal sliding, probably you're looking at, sorry, a focal one, which are probably looking at a consolidation. If you see a diffuse one with thin regular pleura and normal sliding, you're probably looking at cardiogenic pulmonary edema. If you have a diffuse increase in B lines with subpleural consolidation, irregular and thickened pleura, and reduced sliding, you're looking probably at an ARDS or an interstitial disease. This differentiation sometimes can be very helpful in patients where you're deciding whether it's a cardiogenic or a non-cardiogenic pulmonary edema. You have to see a normal sliding versus the reduced sliding. There is also something called as the blue protocol, where you can it can be used to differentiate between the various pathologies. What blue protocol is, this is a profile where you can see predominantly A lines plus the lung sliding at the anterior surface in the supine or half-sitting patients. This profile suggests COPD, pulmonary embolism, some posterior pneumonia. Pulmonary edema is ruled out in this A profile. If you see the B profile, where you see predominantly B lines, this profile suggests cardiogenic pulmonary edema. This usually rules out, you see the number of B lines are more in number and they are diffusely present. This is pulmonary edema. This rules out COPD, pulmonary embolism, and obviously a pneumothorax. If you see A-B profile, where there is massive B lines at the left lung and A lines at the right lung, this is also usually seen with the pneumonia. So to summarize the blue protocol, you have to examine all the zones, zone A, B, C, 1 and 2, that is the upper and the lower part. If you find presence of B profile, that is this, you're looking at probably cardiogenic pulmonary edema. If you see A profile, that is you see a lot of A lines, then you're looking probably at COPD, embolism, some form of posterior pneumonia. And if you see AB profile, we are looking at a pneumonia. Lung A, if you see a profile and plus you are able to find a lung point, probably the patient has COPD, possibly with a pneumothorax. And if you do not see a lung point, then you have to look out for other pathologies. Now, this I have rushed up the things. There are too many things to talk about, but this is in short that you need to know about lung ultrasound in a critically ill patient. Remember that basic, at least minimum, you can find out pneumothorax by the lung point. You can find out the absence or presence of A lines, the B lines, which you can see if they are normal, less than 2 or more than 2. Scan all those zones to see whether they are focal or diffuse. See if there's a lung sliding sign which is present. Look out for a hypoechoic area which can look like a pleural effusion. And if you are good enough, if you have advanced to an intermediate or an expert level, probably you can figure out a focal consolidation. If you do suspect a pulmonary embolism with an infarct, along with the chest ultrasound, you should also get a cardiac ultrasound done to re-echo to look out for pulmonary pressures and look out for any deep vein thrombosis that you can look out for. So with this, I thank you for your patient listening, and I think I'll see you on the panel.
Yeah. So thank you, Dr. Nilanjan. Thank you, Dr. Mehul, for that lovely, kind of a guideline as to what the ultrasound and how the ETCO2 is going to help us. I think now what was remaining was the invasive, but I think we'll ask him the questions, invasive arterial BP monitoring. and I welcome this esteemed panelists today. And let's start with Dr. Arnab. Sir, is there any set guideline as to what are the various parameters which are to be monitored? Is this guideline based on the system involved? And can you just guide us that what all really needs to be monitored?
Okay. So first, thank you CCI for inviting me to this webinar. It's very prestigious every time when I attend this webinar, and I am seeing that daily on the weekly basis, the number of attendees are increasing and increasing. Okay. So once we enter the ICU, first thing, what we see, at least in every ICU in every corner of the world, we at least see a monitor kind of thing which is attached to the patient. So what is that? It's kind of a multi-parameter monitor. Okay. So minimum things what we can see in these multi-parameter monitors, that is the first thing what we see a ECG line. Okay. Then you can see the NIBP, we can see the respiration, temperature, and saturation. So these four, five things are the basic things what we generally see in the ICU. But so there are some different levels of care, some level 1, level 2, level 3 care in the ICU. So what is these levels actually mean? So, for the first level 1 care, when there is no organ support, no organ failure. The patient comes for suppose IV antibiotic or IV fluids for dehydration. So a simple SpO2 monitor or an IBP monitor at least suffice in this level 1 care. The level 2, there would be a single organ failure, but not mechanical ventilation, single organ failure. Probably the patient is coming for our renal replacement therapy, okay, or the patient has an hypotension who is on vasopressor support. So we need a arterial BP tracing for that patient. And in the level 3 care, the mechanically ventilated patient or the patient who have or 2 or more organ failure. So we need a battery of things. Definitely, we need the 5-4 things what I told. But in addition to that, what we need in addition to that arterial BP monitoring. In cases of respiratory problems, we might need a ETCO2 monitoring. Okay, definitely we need a bedside ultrasound or echocardiography machine. Okay, a portable X-ray. Okay, these things are basic what we need for an ICU patient monitoring. Okay, and sometimes we need some advanced things like electrical impedance tomography for ventilation distribution or some transformer thermodilation technique transformer. So these are the advanced things. But different societies have their own have said some things like these things are to be present in ICUs. There are some quality indicators which to be monitored in the ICU. But these are the basic and the advanced things, okay, which are needed in the patient ICU monitor for the patient.
Okay. Yeah, thank you so much, Dr. Arnab. I was mentioning about that we haven't really spoken about the invasive BP monitoring. So, Dr. Nilanjan, could you tell us that now we prefer it so many times, and what are its advantages over an NIBP monitoring?
Yeah. So definitely, invasive BP monitoring is, as Dr. Arnab had mentioned, usually in patients who require level 2 or level 3 monitoring. We require an invasive arterial line for measuring the BP rather than a non-invasive BP monitor. So, in fact, I would prefer to put an arterial line for any patient who is having hypotension or who is having significant swings in the BP, or in fact, any critically ill patient in the ICU. So, the main advantage is, for one, there is a lot of variations, as we all know, with the use of non-invasive BP monitor, like the cuff size and the patient's arm circumference, and again at the site where we measure the BP, it can be in the brachial artery, or we might have to change it and put it on the leg in the femoral. So these sites will all it can lead to an erroneous BP. And most importantly, as in all studies and all have mentioned, that as the BP goes down, as we have developed significant hypotension, our non-invasive BP becomes more and more unreliable. So we really cannot, differentiate much if a BP is 80 by 60 or a BP is 70 by 30 with a non-invasive BP monitoring. Now, the invasive BP monitoring, for one, it monitors the BP beat to beat. Like we get a constant waveform, continuous waveform, which helps in continuous monitoring of the BP. The technique is arterial cannulation. Either we cannulate the radial artery or we cannulate the femoral artery. Sometimes we can cannulate the dorsalis pedis artery also. It is not actually so difficult. It is just like perhaps taking an ABG and just then we use the Seldinger technique and we introduce the catheter inside and using the guide wire and then using the Seldinger technique. And then we connect it to the transducer and most of our monitors, once we connect it to the monitor, we get the arterial tracings. So this tracing, it's a continuous waveforms similar to the arterial pulse. And now the other advantage is the arterial waveform itself. It gives a lot of information about the patient. The arterial waveform itself can help us to see whether the patient is in a vasodilated state, whether the patient is in a vasoconstricted state, and whether there is vasoplegia, etc. Now, another advantage is it can be very useful in continuous hemodynamic monitoring and in assessing fluid responsiveness. So there is something called pulse pressure variation. So it is usually used in mechanically ventilated patients who are sedated and paralyzed. We can see there is significant variation in the pulse pressure. So once we give fluid and we see that this pulse pressure variation is coming down, we can say that this patient is fluid responsive. So that is one of the safe areas or reliable methods of assessing fluid responsiveness. And similarly, there are even advanced cardiac output. Further, if we go a step further, we can even assess the stroke volume and the stroke volume variation, all by connecting a device called flow track or Vigilia, which is can be connected to this arterial cannula. So in these ways, we have there are a lot of advantages. Even the curves can give a lot of information, and definitely it helps in much more, not only in BP monitoring but also in hemodynamic monitoring in the patient as compared to the NIBP. And also even for in case of manpower, in case of nurses, they don't have to continuously tie the cuff, or they don't have to continuously measure the BP or anything. Just once the arterial line is in place, we just have to periodically flush the line so that there is no damping, and we get a continuous BP, and which is much more reliable.
Thank you so much, Dr. Nilanjan. Dr. Arnab, on the same invasive BTP monitoring, what are the pitfalls of this? And does it matter which artery you've chosen, and are there complications related to either?
Yeah, ma'am. So first, once we go for an invasive, we plan to go for an invasive arterial BP monitoring. First, 2-3 things. If we don't cannulate a artery which is small or a distal artery, okay, and you have heard a term called Allen test. Okay, Allen test is kind of thing when I planning to cannulate this radial artery. We have to raise your arm, and for 30 seconds you squeeze the arm, okay, and you make a fist, and then you block that radial artery, and you see the flushing is going on and kind of thing, and there is blockage. So this is a thing which is mandatory for cannulating a radial artery. So we can use the radial artery. Commonly what we use either the radial artery or the femoral artery. Definitely radial artery cannulation from a technical point of view, it's kind of difficult compared to the femoral artery. But the advantages kind of, if a femoral artery, it's close to groin area, so the risk of infection is quite more in cases of the femoral artery cannulation. And there are certain complications what can happen during this arterial cannulation, so you must be aware of those things. There might be a hematoma formation, digital ischemia, okay, some air embolism risk, vasospasm, aneurysm, infection risk. So these are the things you have to check on that. And also important, there are 2 things, leveling is important, zeroing is important, and the dampening. These are the 2 things you have to keep in your mind. So you have to put this arterial BP monitor at the level of your phlebistostatic axis. which is the right atrium. It's you can draw an imaginary line from your fourth intercostal space and cut off at the mid axillary line. Okay, so if the level is higher, the BP would be monitored. BP would be low. If the level is low, the BP would be high. And another important point would be the dampening. Okay, so if the system is under damped due to kind of artifact or some kind of arrhythmia, so the systolic blood pressure will shoot, the diastolic blood pressure will be low. Mean map would be the same, but the pulse pressure would be wide. So, and if the system is over damped due to any clots or any air bubbles, or if there is any kink in the arterial line, okay, so the reverse thing will happen. So definitely what Dr. Mehul has told you, we can regularly flush the system. So there is a also important test you have to know. There's a test is called a first flush test, or a square wave test. Okay, so if there is more than so you have to pull that blue color thing on the transducer system, and the system would be flushed, and you have to just leave that blue color thing. Okay, and if there is more than 2 oscillation, the system is under damped. 1 to 2 oscillation normal, 0 to 1 oscillation is over damped. So these are the things, okay, you have to keep in mind during the arterial BP monitoring.
Dr. Ravi Chandra wants to say something.
Yes. Yes, one more thing I would like to add is that in an invasive BP monitoring, especially when there is a line like a radial arterial line, we should be very careful in patients who are receiving vasopressors like NORAD and vasopressin. These are the ones we should be more careful compared to other patients because these are the ones who are more likely to go into vasospasm and cause the digital blackening or gangrene or any of those things. So that is one more point I wanted to add.
Yeah. In addition to that, sometimes what happens, that's related to your point. If someone nurse falsely just keep that NORAD channel to the arterial line, there would be a massacre. So there would be inadvertent drug administration to the arterial line. So this is also an important point.
Absolutely.
Yeah, true.
Right.
Yeah, thank you so much. So, Dr. Ravi Chandra, thank you for this input. And I would also like you to comment on, like you're doing complex cardiac surgeries. So there is advanced hemodynamic monitoring. Anything particularly you can give us an idea about the cardiac output monitor, and how many days or how long do you monitor with all the particularly I think pulmonary artery catheterization plays an important role in your scenario.
Yes, Dr. Vrushali. So when it comes to other monitoring, basically what we do in either cardiac thoracic surgery is this is the basic, like invasive arterial line is very, very important. One is either you take a radial or you take a femoral, or sometimes we take both, intra-op and then monitoring the post-op, especially in some different situations where like coarctation of the aorta, aortic dissections and aneurysms which have been replaced, where you can compare the arterial pressure and we'll be able to pick up immediately if something is going wrong. That is one thing. And that is with respect to the invasive blood pressure. Coming to the other cardiac output monitoring techniques, we have got, one we use a PA catheter. Then there is a transpulmonary thermodilation, just to name a few which have been used. The other one is the pulse contour analysis. Also, an esophageal Doppler. These are all advanced, but I mean, not all the centers use it. But yes, some of the centers do use it. And then other thing is called bioreactive technology. But then the commonly used ones are the invasive BP, the arterial pressures, and the PA catheter. PA catheter with a copper, and that is connected to a continuous cardiac output monitor, which gives beat to beat. We get to know the cardiac output, and even we'll be able to basically see the trend rather than the absolute value in the post-op period. We'll be able to see how the cardiac output is improving, and then we need to make the other changes, give them fluid or increase the inotrope support or decrease the dilators or things like that. So in those situations, it will have the commonest ones are the arterial pressures and the PA catheter with a copper tip. Yes.
So how long do you generally keep a PA catheter?
Yes. So PA catheter intraoperatively it is very important. Even in the post-operative period, until the patient is hemodynamically stable, because once it is there, we will keep monitoring. And then when when the inotropic requirements is quite low, like no inotropes or even minimal inotropes, to that extent, we need to monitor the PA catheter. After that, we will be able to take it out. That's one thing. The other thing is wedging, because if we keep it for a quite long time, there could be other things which, many situations it can, because of, when you keep on trying to do the wedging and other things, it could lead to pulmonary infarct or things like that. So earlier we want to take it out, that will be better.
Great. Thank you so much, sir. Dr. Thakkar, good evening, sir. So I think, sir, you need to unmute yourself, sir.
Good evening. Good evening, Vrushali.
Good evening, sir. Good evening. So you
Yes.
just spoke about the USG and the IBP. How does the 2D echo help you, in the hemodynamic monitoring, and like particularly in your case, the pre-operative and the post-operative 2D echo? What are the things which you're looking for, and how do they aid in making some decisions regarding to surgery, be it the cardiac surgeries or the lung surgeries, like then aortic and the lung vascular surgeries as well, sir?
Vrushali, before I answer this question about 3D echo,
Yes, sir.
I want to just continue on what Dr. Ravi Chandran said on PA catheter. Like he said, the PA catheter which we keep in the immediate post-op and in the intraoperative, for all transplant patients, we always have a PA catheter. And for most complex cardiac surgery, PA catheter is a very useful tool because it tells you the filling pressure of the left ventricle from the right side. So whenever the left ventricular function or the cardiac output drops, there is an increase in the left ventricular end diastolic volume, followed by an increase in the left ventricular end diastolic pressure. So if there is no mitral stenosis and there is no pulmonary venous stenosis, the left atrial pressure reflects the left ventricular end diastolic pressure. And the pulmonary artery diastolic pressure will reflect the LA pressure, provided there is no pulmonary venous stenosis. So it gives us a view of the left ventricle from the right side. And therefore, by monitoring the pulmonary artery diastolic pressure, we can deduce. So we don't need to wedge again and again to see the cardiac output. If the pulmonary artery pressure, diastolic pressure is low, then we know that the filling pressure of the left ventricle is little low. And if it reaches beyond 24, pulmonary artery mean pressure reaches beyond 24, there is a chance that the patient is going to go into pulmonary edema. It's only when you have reasonably filled up the left ventricle, then you go up on the inotropic support. So in management of post-cardiac surgery, cardiac output, management of low cardiac output, you have to optimize the preload first, then you optimize the afterload, increase the contractility, and manipulate the heart rate. The heart rate is manipulated by isoprenaline or by pacemaker or by astatine or some drugs which increase the chronotropic effect on this. Now, echo gives you the same impression. It gives you, echocardiography will tell you whether there is dilatation of the right atrium, right ventricle. It will give you an idea of the pulmonary artery pressure. It will tell you what is the status of the inferior vena cava. And these things are variable. Like IVC, most of the critical care specialists are just going by dilatation, distension of the IVC and the collapsibility. We need to compute right atrial dilatation, presence of tricuspid regurgitation, dilatation of the right ventricle and pulmonary artery pressure along with IVC to get a reasonable idea about the filling pressures of the left ventricle or the right ventricle. So it is very important to understand I personally prefer to use the pulmonary artery catheter rather than echo, because we have to depend on cardiologist or on anesthesiologist in the post-operative phase or on the intensivist to tell us more about the filling pressures and the contractility. But of course, it is vitally important monitoring tricuspid regurgitation, TAP C, and the filling pressures of the right side. Would you agree, Dr. Ravi Chandran?
Yes, sir, absolutely.
So we use the pulmonary, and like Dr. Ravi Chandran pointed out, the moment we find that the patient is hemodynamically stable, then the first thing we do is we take out the PA catheter, and a day later we take out the sheath also, because once you find that the inotropic requirement and the hemodynamic stability is attained, then we want to quickly take out this, because chances of infection and injury and bleeding can occur.
Right, sir. Right. Thank you so much. Dr. Mehul, there's a question from Dr. Datta from West Bengal, that do you always hold the probe of the ultrasound probe at right angles to the rib?
No, not always. See, you have to see both the views, and you have to make sure that the marker is always on their left side. I mean, these are techniques which, for a comprehensive view, you want to be quick. Also, when you want to, if you use the linear probe, you're supposed to keep it between the ribs, because there you are only looking at the lung point or presence or absence of effusion, or you want to tap an effusion. So you can keep it horizontal to the ribs and when you're using a linear probe, but when you're using a phase array probe, you can keep it the way you want. But usually the protocol is for examination in the perpendicular side.
And I think it's finally how you orient to, using the probe is like, you really have to play with the probe and understand how the orientation is.
You get some set rules, but then you have to develop your own techniques to scan faster.
Yeah. Thank you so much. Now, any of you can enlighten me, enlighten all of us, that is there a role of the ETCO2 monitoring in non-intubated patients? Like, are there mechanisms or other certain things which are being developed? And this is particularly relevant since when we have our patients, particularly our COPD patients, who are having, who come to us with a CO2, we put them on a non-invasive ventilation, and rather than blood gas and they're going into a complete state of unresponsiveness. Is there any way we can use an ETCO2 monitoring?
So, until recently, we used to use it only in intubated patients. But nowadays, there are a few studies that have come up that we can use it in patients on NIV as well, if we connect it to the NIV mask. Now, the main problem with patients on NIV is that the different patients, first of all, the fitting of the mask might be different. So there might be significant leaks through the circuit and coming out through the mask. So we may not get an accurate measurement of the ETCO2. And the second problem is that, as I showed before in my slides, when the patient is breathing spontaneously, there might be different notches on the ETCO2 on those ETCO2 curves, and this can certainly change the ETCO2 values. So ideally, the best ETCO2 trace is that which we obtain in a mechanically ventilated patient, sedated and paralyzed. That gives an accurate measurement of the ETCO2. But in NIV also we can use, especially we can get to know whether the patient is hypoventilating and there is a serial increase in the ETCO2, and it can give a indication for whether we have to mechanically ventilate or intubate the patient. Any other thoughts from others?
No, so I agree with you. We usually use it in intubated patients, but if you are using it, I have personally never used it in an NIV with an NIV, but probably you can use it in combination with all the other clinical signs that you see that a patient is getting, is tiring out and probably might need an invasive ventilation. So probably it can be used there. Yes, there are some studies which I also read, but probably we have not started using it. Yes, we should start using it.
So there is a two concept, mainstream ETCO2 and the side stream ETCO2. Okay. So mainstream ETCO2 for intubated patient, we can use the side stream ETCO2 system, where actually the transducer is not directly into the system, it's somewhere outside, and the sample gas is collected there. Okay, and you can measure the EtCO2. Okay, so the CO2 levels. Okay, so this is called side stream EtCO2 system. So this can be used for the non-intubated patient.
Like we just spoke about, so since there are much studies, but we can think about, and start extrapolating our own data, and maybe not to rely it completely, but just see the trend, whether it's going downwards or it's going upwards. Okay. Dr. Nilanjan, whenever a patient comes in hypertension to the emergency unit and then eventually to the ICU, we are always in a rush to put in IV fluids, and but in some patients it obviously is doing much more harm than what is anticipated. So you just told us about the fluid responsiveness, in short, in your EtCO2 presentation, that but how will you think about the same in an invasive arterial BP monitoring role? And in such cases, in the ICU, not the cardiac or the post-cardiac surgeries or post-lung surgeries, would you think of placing in a pulmonary artery catheter?
Thank you, ma'am, for asking this question. So, fluid responsiveness. First of all, the concept of fluid responsiveness, it means that only give IV fluids to a patient who is only going to be responsive to those fluids. Like, I should give fluids to this patient only if the IV fluid is going to increase my hypotension or going to increase the tissue perfusion to the other organs. Otherwise, if I give fluids, it is going to do more harm to my patient than good. So for this, ideally, we should not give IV fluids to a patient without assessing whether the patient is going to be responsive to the fluids or not. So there are various techniques for assessing fluid responsiveness. We can start with there are static measurements of fluid responsiveness, which we nowadays rarely use. And one is CVP, and the one, as you mentioned, is the pulmonary artery catheter. So the pulmonary capillary wedge pressure that we get, if it is very low, then maybe the patient is fluid responsive, and giving IV fluids would help in increasing the perfusion to the other organs. But these are actually static indicators. Nowadays, we have much more better dynamic methods of assessing fluid responsiveness. Like starting from the passive leg raising test, which is a simple method which can be done in every patient. We just need to make the patient lie flat and then raise their leg end to around 45 degrees, and we measure and we see whether the BP is increasing. The theory is that there is an increase in the venous return, which will increase. That's just like an auto infusion of fluids, which will increase the BP. So even this can be further, we can monitor it real time by using an echo and seeing the velocity time integral or the left ventricle outflow, whether it is increasing. And again, coming to another step of fluid responsiveness is using the invasive arterial line. We get the pulse pressure variation, and we can see the pulse, the contour of the pulse, the arterial pulse waveform, and from that itself we will be able to know whether the IV fluids can increase the BP or not. As Dr. Thacker had mentioned, the 2D echo is a very good tool to assess fluid responsiveness, not just the IVC as he mentioned. IVC is certainly one of our favorites in intensive care, like seeing whether the IVC is collapsing with respiration. If it collapses more than 50%, we are reasonably safe to give some amount of fluid, which would increase the BP. But then, as I said, there are many other things in the echo also. We need to see the overall LV and then the right ventricular functions and everything before we can fully conclude whether to give a large amount of fluid. And then there are advanced cardiac output monitors which help in monitoring, assessing fluid responsiveness. We can monitor everything from starting from the stroke volume variation, the extravascular lung water, and there are a lot of things that this cardiac output monitors can precisely help us to determine whether the patient is fluid responsive or not. And the ultrasound also, as Dr. Mehul had mentioned, the presence of significant B lines, which again shows that a patient may not be fluid responsive. We might have to limit our giving our fluids and concentrate more on vasopressors to increase the BP. So fluid responsiveness is a huge topic. There are many methods, dynamic methods of assessing fluid responsive. And the moral of the story is that please assess fluid responsiveness before giving or rushing in fluid. Like if you are going to give IV fluids to a patient who is having a very severe LV dysfunction, or a patient who is pulmonary edema going into shock, or a cardiogenic shock, you are going to further precipitate the pulmonary edema, and this is going to worsen the patient's hemodynamics as well as the respiratory status. So, fluid responsiveness certainly very important in our ICU.
So on that, Dr. Arnab, I would like to ask you that a patient who has right ventricular hypertrophy, or there is pulmonary, or they have pulmonary hypertension, how do all these modalities work in that case? They also can come in a phase where they are actually fluid deprived or they are dehydrated. So how do you judge? Because your CVP will not really give you the it might be falsely high. So you need to unmute yourself.
So definitely, ma'am, CVP has a very good place for fluid responsiveness in the past era, but definitely with time and these advancements of advanced hemodynamic monitorings and things, okay, CVP is going away from the practice. But still, see these complex hemodynamic monitorings are not available in every corner of the ICUs in every area. So still, CVP plays a definite role in these kind of places where there is a decreased CVP, you give fluid, increased CVP, you hold fluid, give vasopressor. These are the basic concepts. But with this complex hemodynamic monitoring, as the previous panelist also told us, that we can had a definite idea of the stroke volume, the cardiac output, the filling pressures. With a hands-on echo, okay, we have a eyeballing on the overall any cardiac dysfunction is or there or not, okay. And with the IVC monitoring, okay, so definitely IVC monitoring also has its own fallacies kind of thing, but still IVC monitoring, it's kind the thing which is done every ICU. I think in every ICU we are doing everyday IVC monitoring. On basis of that, we can also think of this can be optimized if the IVC is dilated, hold fluid, vasopressors, IV is collapsible, give fluid. Okay, another thing is lung USG. This is also holds an important factor in cases of fluid responsiveness. Suppose a patient come in a shock state and you are giving fluids and you are doing serial lung USG, and once you are seeing that there is appearance of B lines in the lung USG, so that means the lung is getting flooded with extra volume. So you have to hold the fluid at that moment. And with this this advanced hemodynamic monitoring, like transpulmonary thermodilution technique, where you can exactly give an idea of extrapulmonary vascular water. Okay, so from that you can also get an idea. So this is we are giving extra fluid, so we have to hold fluid. So these are the things which, apart from CVP, with advanced monitoring, we can have an idea.
And the CVP along with the USG, the presence of B lines.
USG nowadays a very good tool at bedside.
Yeah, absolutely.
It's available in everywhere, almost in every ICU now. USG, bedside USG are essential tools. Okay.
True, sir. True, sir. Dr. Thacker and Dr. Ravi Chandra, sir, I just wanted to ask you about the commonest issues post a pulmonary endarterectomy for a CTEF, and how would you collaborate with the ICU team? How should the ICU team suspect or deal with these with respect to the ultrasound and the various lines? Particularly, I'm interested because assuming that since it's a pulmonary endarterectomy, we won't be putting in a pulmonary artery catheter in these patients.
You're talking about chronic pulmonary.
Yes, sir. For a chronic pulmonary hypertension, when a patient undergoes a pulmonary endarterectomy, so what are the complications which you commonly see, and how is the ICU team to monitor for these, particularly?
See, chronic pulmonary thromboendarterectomy is a very, very complex operation, which is done by reducing the patient, going on cardiopulmonary bypass, reducing the temperature to 18 degrees, suspending the circulation, means you go on circulatory arrest, you open the right pulmonary artery and remove the thrombus, find a plane between the plaque and the wall, the media of the pulmonary artery. You remove the plaque, and you know that your removal is complete based on two factors. One, you will see a tail at the end of the plaque which you have removed. That's the thrombus. The plaque is of a thrombus. And second is there will be no residual pulmonary hypertension. If you find that there is residual pulmonary hypertension, that means that your thrombectomy endarterectomy has not been accurate. You need to do more. Now, there are 4 stages of this endarterectomy. One is the stage 1, which is in the main thing, and stage 3 and 4 are in the smaller vessels. The stage 4 is when there are no clots or no chronic thrombi present, but the pulmonary artery pressure does not come down. These are actually candidates for transplantation. The other complications that occur, same thing you do on the left side. So you do a circulatory arrest, remove the clots, the chronic clots, the chronic thrombi on the right side, then restart the circulation, go on to the opposite side of the table, once again cool the patient, and now stop the circulation again, and then do the thrombectomy on the left side. And then the complications that would occur would be that there will be reperfusion injury, like how you get when you do bilateral carotid endarterectomy, or when you get repair of the coaptation. These can produce an overflow phenomenon. Dr. Ravi Chandran, feel free to add in your comments. Then what happens is we fill up after we've done the endarterectomy, we fill it up with saline to see if there is and ask the anesthesiologist to ventilate. If there is any air bubbles coming out, then that would suggest that there is an injury that we have occurred, which is a surgical injury. You will find in the post-operative periods after this that there is hemorrhagic effusate, a pulmonary edema, which is occurring in the post-operative phase. Now, these would suggest either there is a surgical injury or the patient is gone into pulmonary edema because of the air-blood phase getting violated. Then the other complication of this is reperfusion injury, which means that there is increase in edema. These patients need to be treated with patients being put on ECMO post-operatively, extracorporeal, and wait for the healing to take. So if we identify an injury, we fill it up with Surgicel, induce ECMO, put the patient on ECMO and wait for 24 to 48 hours to take care of the patient. Chronic pulmonary endarterectomy for pulmonary hypertension, like CTEPH operations, the endarterectomy, is a very complex operation. Very few surgeons do it. And it is not something that you will see commonly in your operating listing.
Yes, sir. A few things to add to that is that along with this, as sir rightly mentioned, because we cool the patient, whenever in any situation, the more you cool, the more chances of bleeding in the post-operative period. So we should be very careful and watch bleeding in the immediate post-operative period. That is one thing. The other thing is it could develop a pericardial effusion, and that could lead to a tamponade or a hypotension. Then also it could lead to arrhythmias, which could be potentially fatal. Okay, just to enumerate some of the complications which we could be seen in the post-operative period. And atelectasis, along with reperfusion injury and few other things, atelectasis by itself, it has to be identified and to be treated appropriately. Other than that, delirium and wound infections are the other ones. And coming to the assessing in the post-operative period, after the surgery, it could the patient could fall into any one of 3 categories. One of them, which is 70% of the patients fall into that category, in which case there is a decrease in mean PA pressure and decrease in pulmonary vascular resistance, and with an increase in cardiac output. Okay, these are the ones uh, and also there will be systemic vasodilatation. So in the these are the ones which do well, and we may have to even come down on the supports and to reduce the cardiac output. The other category, which is like around 20% of them fall into this category. In this situation, there is an increase in the PA pressure, increase in the cardiac output, and there will be systemic vasodilatation. So these are the patients who are increased risk of reperfusion, pulmonary edema, and right heart failure, and those things. They will require diuretics and close monitoring of cardiac output. The other 10% of the patients are the ones who do not fare well. In these cases, they'll have an increase in PA pressure along with a low cardiac output. That is the one we need to watch out for, low cardiac output, and do appropriately. As sir has rightly mentioned, they may require an ECMO or even a continuous veno-venous hemodialysis. These are the different categories which they come into. That is in the immediate post-operative period, Madam Dr. Vrushali.
Yes, I think as difficult as the surgery is, the post-op period, it can be as difficult for such an individual. But I think it's worthwhile, considering that they could be on lifelong therapy and the reduction in their overall quality of life. So, Dr.
It's
Mehul,
quite rewarding. It's quite rewarding.
Yes, sir.
Yes, sir.
There is one very important physiological point which you have rightly alluded, is that when you do a complete endarterectomy, the amount of blood coming back to the left ventricle is much higher, because the left ventricle, because of the severe pH, is not accustomed to getting the full cardiac output. And therefore, many of these patients are going to go in the next 24 to 48 hours into severe pulmonary edema. So what I do is, after we do this surgery, we put the patient electively on ECMO for the next 72 hours. And then we wean the patient off ECMO. We do the same thing for lung transplantation for idiopathic pulmonary arterial hypertension. Whenever there is severe pH, the left side of the heart is not used to getting such a, like all 5 liters of volume, and it is not trained to get into the to handle that circulation. So chances of pulmonary edema, which usually occur after 48 hours to 72 hours. So what I do is I wean the ECMO off after 72 hours. And that I do it electively before the patient goes, because once the patient goes into pulmonary edema, it will be so sudden that you will not get time to put the patient on ECMO, and you may lose the patient.
Yes, sir. Other thing is 1 or 2 points which is not related to the critical care but directly related to CTEF is that there should be minimum on 3 months of anticoagulation before we decide to take him or her up for surgery. That is one thing. The other thing is usually they take 12 to 14 months from the history of having the previous DVT. Venous thromboembolism to become either symptomatic or to have signs of PH. These are the important things, man. And the other thing, there is no direct correlation. There is no direct correlation between the severity of a previous DVT. Even someone having a very trivial DVT probably may go on to develop a CTEF.
Yeah.
The 3 to 6 months of anticoagulation before is a very important point. We should not operate on.
Very well taken, sir. Yes, sir. Very well taken. So now we again go to the UIC part of it. Dr. Mehul, can you just, a patient just comes in hypoxic. So how will you use the ultrasound really in this case, even before your X-ray machine arrives? A quick recapitulation of whatever you've already told us. Really.
So if you see a patient of hypoxia, first, obviously, along with the history taking and whatever clinical and bedside examination that you did, you saw the parameters, you've connected an ECG lead, you probably get a fair idea where you're looking at. But in a hypoxic patient, if it is a life-threatening condition like hemodynamics are abnormal, you are worried about 2 things. Either it's a pneumothorax, as it's a pulmonary embolism, either it's a cardiac event. So a USG there will help you bedside. If till your X-ray machine comes, you have connected the ECG leads, you can just rule out a pneumothorax by getting a lung point. You see the lung sliding, whether you can see a consolidation If you see a lot of B lines, but you don't see them, there are some spaces in between. There is normal areas of lung. You scan the anterior part, you find separations of B lines. You scan the posterior part, you find them, they are homogeneous. Probably you're looking at an ARDS pattern. If you see mild effusions along with the increase in P lines, probably patient is in cardiogenic pulmonary edema. Also, if a patient is breathless and you don't know what has happened, specifically it's a trauma case or tuberculosis case, look out for cardiac tamponade. Just put a probe, even though you may not be trained into doing cardiac ultrasounds, but just putting a probe there, you can come to know whether there is any pericardial effusion, which you can detect. And in an expert hand, if you see focal consolidations, maybe look out for DVTs and think of pulmonary embolism.
Yeah, that was the next question I was coming to. So both of you, like you have a suspected pulmonary embolism, but the creatinine is way too high. And the ECG is not really showing us the classical signs except for the tachycardia. So how will UHD help us? Both Dr. Nilanjan and Dr. Mehul can just chip in. I know till the time we actually come to getting the creatinine down and maybe doing a CTPA. But till that time, what are the pointers on the UHG and otherwise also that this is really a pulmonary embolism? So UHG echo also included.
You start first.
Okay, fine. First thing is ECG, as you have told, sinus tachycardia is non-specific, but it is the most common ECG finding in pulmonary embolism. And the most specific one is getting an S1 Q3 T3 pattern. But that happens only in probably 10% of our patients. Now, history taking, of course, is very important. Taking a history as to assessing the risk factors. Then coming to the ultrasound, I think rather than the ultrasound, it is the echo, or we can say the echo probe of the ultrasound, which helps us more in assessing. We particularly have to assess the right side of the heart. There is usually significant RA-RV dilatation in pulmonary embolism, and there is usually the if you see the diameter of the right ventricle compared to the left ventricle, it is less than 0.8 times the left ventricle size, and there is a significant increase in the right ventricle size in case of pulmonary embolism. Also, if you are really good in ultrasound, we can measure the tricuspid regurgitation, which is usually more in case of pulmonary embolism. And the IVC is usually dilated in case of pulmonary embolism. So all these things certainly they help us in increasing our suspicion of a pulmonary embolism. Even you might even see the embolus sitting in the right ventricle sometimes. So yeah, Dr. Mehul, you can continue.
Yeah, so that's how it is. Any test that you do is going to be confirming your suspicion what you had clinically. So like he said, clinically you suspect, you have all those scoring systems, you suspect there is an embolism. And obviously the cardiac echo or the cardiac ultrasound is going to be more specific. If you can find a DVT and you're suspecting embolism, then probably that is going to be more of a pointer. On a lung ultrasound, probably what you can get is pleural base, hypoechoic areas. You can see some consolidation, wedge shape opacities, maybe a mild pleural effusion along with that. But those are not specific signs for an embolus or an infarct. You have to see it in a combined state. Like if you have RA-RV dilated, you can probably suspect a DVT. You can see a DVT if you can do a Doppler. And obviously you can see some lung hypoechoic subpleural areas. Then probably you can think of it as a case of pulmonary embolism, and in such cases treatment matters till the patient becomes stable. You can't wait for the creat to come down, or if patient is hemodynamically unstable, probably it may never come down, so you need to treat the patient.
Absolutely. Dr. Nilanjan, can you just elaborate on the central venous oxygen saturation? Can it substitute for an arterial oxygenation saturation? And and what are the problems with it? How do you go about it?
Okay. So central venous oxygen saturation, that is what we get from a central line. If we take a sample from the central line, Before there was this, when our PA catheters were common, we used to get a mixed venous sample from our PA catheters. But now, except sir said, probably for the complex cardiac surgeries, we use a PA catheter. In our medical side, for patients with sepsis and other things, PA catheter is almost out. We certainly use the central line. So the basis for this is the central venous oxygen saturation. It is based mainly on the delivery of oxygen to the tissues as well as the utilization. So, in the most important problem with this is if we classify the different causes of shock. Broadly, we can classify it as cardiogenic, obstructive, hypovolemic, and distributive. So in distributive shock, especially in septic shock, we'll get a higher SCVO2. Our normal central venous oxygen saturation, which we expect is about 65%. But what happens in sepsis? In sepsis, usually we have a hyperdynamic circulation. It's not like the other cardiogenic or the other types of shock. We get a hyperdynamic circulation, and it is the ineffective utilization of oxygen by the mitochondria which occurs at the cellular level. So our SCVO2 is actually going to increase. It is going to be like in very severe sepsis or septic shock, we might even get up to 85-90% of the venous oxygen saturation, which is obviously a wrong indicator compared to our oxygen, arterial oxygen saturation in our arterial oxygen. So that's going to be a problem in septic patients, and in cardiogenic patients with cardiogenic shock, we are going to get an exceptionally low central venous oxygen saturation. Even in our hypovolemic shock, in cases of significant hemorrhage, that again is going to decrease our SCVO2. So SCVO2 is also a marker of hemodynamics, fluid responsiveness, or importantly, it helps in classifying our different types of shocks. So, yeah.
Yeah, thank you so much. I'll take a couple of questions from our viewers. So, one is from Dr. Mahendrakar from Maharashtra. Is that which monitor has a good, which monitor manufacturing company is good for an ETCO2? Any of our intensivists can chip in?
Right, yeah.
No,
So
multi-para monitoring. We see when we need an advanced multi-para monitor, the Philips monitor they are having. Basically, we need a place. We need to calibrate it, and so that we can connect the ETCO2 device into the monitor. See, some monitors are having only three areas. We can monitor with only three things. Like some will be having only heart rate, BP, and saturation (SpO2). Some will be having four parameters that can be monitored. Some will be having five. So it depends. Advanced, certainly Philips monitors, as far as I know, the advanced monitors, they can have up to five parameters that can be monitored. So one of those parameters, we can use the ETCO2 to monitor one of those parameters.
Yes,
So it is just the monitor and the probe.
MP20, MP30, MP40, 50 has sometimes more parameters. Okay, so that can be used. Yeah, Philips is good one. Yeah.
Now I will come to the last 3-4 questions.
One point I want to add. Yeah.
Yes.
So along with Philips, I have seen in some peripheral centers, even the Medion ones are used. So obviously, yes, Philips is going to be a better one. But if the budget is an issue, maybe local manufacturers can help you out.
Okay. Now I'll come to the last 10 minutes of our session today. And the one interesting and important question which I would like to ask everyone is that where do we stand medico-legally for ultrasound in critical care as well as pulmonology? One, and where are such courses offered? So keen to a level 1 or 2 operator system which is done in the UK. And what is the status of such courses? How, like I again said, where do we stand medico-legally in this?
So, madam, I can share my experience. Okay, one of my experience. So, during the COVID time, so there were death audit by the governments. The government officials are coming and they are doing a death audit. So, I was asked a question. Have you done daily USG, lung USG for your patients? So, it is kind of so much important nowadays in critical care. Okay, so even suppose a patient who come with a trauma, and you, if you are not, if you you have not done a e-fast, so you are a criminal. You have not done a e-fast for a trauma patient. Okay, you have done a pleural fluid aspiration without USG guidance. So this is a criminal offense. Okay, so even my college life, my professor asked to, yes, percuss this area. Okay, this is dull. Put your needle here. So these things are actually goes away. Okay, so
No,
now
I completely agree with that. I'm saying as pulmonologists and critical care who are not radiologists.
Yeah, ma'am. Yeah, this is mandatory nowadays. If WinFocus, it's a globally accepted company who are doing regular lung USG courses. Okay, so in critical care, so this is I on one of the best courses what I have done during my career. Okay, so WinFocus definitely had a good quality of course during this lung USG, and also Medanta is doing such kind of courses. Even a big institution
And
have.
the critical care society is also doing these courses.
ICCM, yes, ICCM is doing this course.
Yes, Mehul.
Yeah, so I think I did a little cheating in there. I mean, in Maharashtra, there is a necessity of having a PCP entity registration where without having a formal training, you cannot get a hands on an ultrasound machine. Okay, so the easy way out is to undergo 2D echo courses, which are freely available. Even a pulmonologist is supposed to ideally know some 2D echo. So first of all, get your PCP entity registration if your state demands it by getting a 2D echo certification, which are simpler to get. And then you grow, you learn, you sit with your intensivist and you see patients, and that's how you're going to learn. And obviously, if you get ultrasound courses, I'm sure South May Dr. Priya is helping out with many courses like this. And you can find short 1 day, 2 day courses, but probably knowing the basics of ultrasound and all, doing a 2D echo for a couple of months mandates, you take care of the requirement, which is mandatory, and also you learn a lot in such courses.
Yeah, and I think a daily practice is daily or maybe a frequent practice.
Yeah, it's end of the day your practice, but at least getting a certification is necessary in Maharashtra. At least I'm not sure about the PCPNDT laws in other states, but at least you can get that. That is valid.
Ma'am, so language is so popularized, So in our ICU, I think if people are doing USG guided peripheral line placement also. Okay, so patient is edematous, so they are doing USGs to do the peripheral line also. It is so much popularized, In case of AKI, there are so much kind of indexes come, resistive index. In neuro ICU, you are seeing optic nerve sheath diameter, transcranial Doppler. So USG is everywhere in the ICU, in every department of the ICU, every corner of the ICU. So it is mandatory. You have to have a idea of the USG. Your practice will change definitely. After doing this kind of courses, your practice will change.
So that gets me a question from Dr. Satish Jagdishan from Karnataka, who says that would non-invasive monitoring become the future of critical care?
So non-invasive in the sense like hemodynamics, or see in the there are.
So we discussed about invasive arterial BP monitoring. We discussed about the CBP. Yeah. So I think the ultrasound forms into the non-invasive really. Yes, sir.
Okay. So in the case of hemodynamic monitoring, there are invasive as well as non-invasive. So invasive definitely like the invasive arterial line, the advanced, the cardiac output monitor, and all of them are invasive monitoring. Okay, but they are giving us a very good idea about a lot of parameters like the stroke volume index, the stroke volume variation, the pulse pressure variation, etc. So these cannot be measured with any of these non-invasive devices. The non-invasive monitoring, which we can use for hemodynamic monitoring, it is our 2D echo. It is not invasive, but it gives a very good idea about the hemodynamic status of the patient. The ultrasound is also non-invasive. So means a trained ultrasound or a echo person who is trained can certainly use these benefit rather than using a cardiac output monitor when the person is not trained in it. You can use your ultrasound echo itself and get a fair idea of the hemodynamic status of the patient. And another thing I just wanted to add about your ultrasound thing, like POCUS is something that everybody means the emergency physician at least and the intensivist, they are expected to do point of care ultrasound. So point of care ultrasound is legal. Means we are not giving a printed report and handing it over to the relatives or the patient bystanders. We are assessing it for our benefit. We are, doing a ultrasound, point of care ultrasound, to assess whether the patient is going to be fluid responsive or not. And again, coming to USG guided procedures, I mean, there is no problem in doing a blind technique for a CVC insertion, or blindly doing a pleural tap or an ICD insertion. But definitely our accuracy is increasing using an ultrasound. So ultrasound training is very mandatory for pulmonology. In fact, for all departments. In the legal status, what you are saying, I think giving that is for a routine ultrasound or routinely a stable patient who is walking into the OP, perhaps maybe a pulmonologist or a critical care physician. They shouldn't be doing an ultrasound. It is only the radiologist. But for focus, yeah. For focus,
Focus,
it's fully
we've
legal.
been doing that, since our
Yes.
residency days. It is us
Definitely.
who do the ultrasound.
So that
taking
is,
help
we are
of-
expected. If we are not doing it, actually, then that is an offense. We should be doing it for our patients.
There's a question from Dr. Madhav Kulkarni from Karnataka, and I'm not really understanding the question. I just see this. Why does RV by IVC size in P? Or does he mean what is the RV by IVC size in P? Does it have any meaning really? I'm not sure about this. Anyone who wants to take this on? I didn't really get the question. This is all it is. So Kulkarni sir, if you could be more precise. And then I come to another very interesting question, which is, by a surgeon. And it is like there's always a conflict between the surgeons and the intensivists in managing the critically ill post-operative patients. So how do you get a middle ground in this? And where do you define the roles? What is the role of the surgeon and where is the role of the intensivist?
I think first a cardiac surgeon should
Yeah.
speaking also.
I think both should realize that they are working for the good of the patient. One thing most important.
It's a teamwork. It's a teamwork, and everybody has
Yes.
their own strengths and weaknesses. Yeah.
Yes, Thacker sir.
Thacker sir, please.
What I want to suggest is, just a thought is that both have a different worldview, but both the worldviews are necessary. The paradigm of the surgeon, the paradigm of the intensivist is to see that the patient goes out of the ICU. The paradigm of the surgeon is that the patient goes out of the hospital and continues to live a normal life with his family and with his and functional in his distance. So because of this paradigm, the difference in these two paradigms, there is a lot of difference in opinion of the management and when to intervene, when not to intervene. These are my thoughts. I have read a chapter in which I forwarded to you, the chapter in Dr. Ripi's book on how to the roles and responsibilities of the two different distinct. Now, there are some intensivists who are very, very aggressive and they say we will not take any suggestions from the surgeons. And there are some surgeons who are so aggressive that they overrule the intensivists. That is counterproductive for the patient. Both these approaches are. And as Dr. Nilanjan said, that it is a teamwork and we have to share each other's viewpoints. But I think the fundamental differences are that the intensivist has a lexicon of options to correct a parameter, which surgeons are lacking. For example, if a BUN is elevated, an intensivist has got various methods by which the BUN can be reduced or a parameter can be modified. Whereas the whole perspective is in the minds of the surgeon. This is what I have experienced in my interactions with intensivists.
Yes, sir. Also,
One more thing which I wanted to
also-
add was one. Yes, sir.
sir. Also, the perspective that a surgeon gets pre-operatively, intraoperative, and post-operatively, it's like a bird's eye view. He would have an overall picture of what is happening. So that continuity will be there. If that could be convey to the intensivist or any physician whoever is taking care of the patient.
That is what I was just saying. There should be conversation between the two.
What
Yes,
is this
ma'am.
called by
Exactly.
multidisciplinary rounds? So surgeon is giving round at a time, the intensivist come at another time. He has given some rounds, he have given some inputs, and sometimes there must be controversy. So there must be a multidisciplinary round where the surgeon or intensivist come at the same time, discuss with the registered all and discuss among themselves the things, and the things got easier. Okay.
That is very
I think
important. I think multidisciplinary is very important. I think we should have a fixed time where the surgeons and the intensivists come together. They take the rounds, they make their own comments, they discuss each other, and then they make a plan for the day. And I think that is very important. And then they monitor it every 4 hours so that they can make changes and be flexible.
Yes.
Yes.
I think this was an absolutely brilliant session in which, though we have the monitoring devices, we always first start with the history and the clinical presentation. Then we have the non-invasive monitoring devices, and we have to use them in the right setup. We have the invasive monitoring devices, and again, one single device is not what is going to be sufficing us. We have to use the clinical history, and combine it with the non-invasive oral history and the dialogue between the treating team. I think that is of utmost importance. Despite that, there are going to be problems, and most of the times we're going to face success. So I think let me close today's session. I thank all the panelists. I thank CCI for this opportunity for us to be present here, and trusting us with this job that we could carry and will carry on such topics in the future. And thank you, audience, for your patience hearing and for the questions. And I thank everybody.
Thank you.
No, thank you very much.
Thank you.
Vrushali,
Thank you for
and
the good
Dr. Vrushali.
moderation. Yeah.
all the
Wonderful.
gentlemen.
Wonderful moderation, ma'am. Wonderful moderation.
Excellent.
Very,
Yeah.
very interesting meeting.